So you may have learned that signs of cardiac ischemia include ST segment depressions and ST segment elevations. And in this video, we will go over the physiology that leads to these changes in an ECG. But before going over each of these, first we'll go over the criteria demonstrating the characteristics that define an actual ST segment change. And then we'll move over to the physiology and what causes specifically ST segment depressions as well as ST segment elevations. If you'd like to skip over to any portion of the video, you can use the timestamps in the description below. So first we're going to go over the criteria of an ST change. And for both ST segment elevations and ST segment depressions, the thing that we have to pay attention to is something called the J point. The J point is defined as the end of the QRS and the start of the ST segment. So if we were to look at an ECG as an example, we got your Q, R, S, and T, and as well as your ST segment right in between the two, the S and the T. So the J point is the end of the QRS and beginning of the ST segment, so which is right over there. That's the J point. I'll erase this line here to make it a little bit easier. That pointy bit right over there is the J point. And in order for the ST segment that follows the J point to be considered an ST segment elevation or depression, this J point must be at least 1 millimeter above or below the isoelectric line. And with the isoelectric line, what you're looking for is the baseline of the ECG. So in this case, it'll be somewhere around here, which is right between this light line and that light line, about halfway in between there. And so that means that for this ST segment to be considered an ST segment elevation, the J point must be at least 1 millimeter, which is one small box above this isoelectric line. So it must be, since the isoelectric line is right here, right in the middle, let's say halfway in between these two light lines, these light lines here, the J point must be at least halfway between these two or above in order for the ST segment to be considered an ST segment elevation. In this case, we have a normal ECG. So we see the J point is right around here, which is about halfway between the two small lines here where the isoelectric line passed through. So it would not be considered an ST segment change. If, for example, we saw that the QRS went up, QRS went like this, and the J point was down here and it deviated out that way, and then it went back, then the J point would be somewhere around here, or before the ST segment started, and that would be considered an ST segment depression. If the ECG looked more so like this and it went above, then the J point would be right over here, and it's evidently much higher than the isoelectric line down here. This is greater than 1 millimeter. In fact, it would be right around, this is one small box, 1, 2, 3, 4, 5. So it'll be about 5 millimeters. And if I were to draw out the general shapes of what the ST segment elevations and depressions would look like compared to the normal, it would more or less look kind of like this, where this would be the normal, this would be the elevation, and this would be the depression. As you may see, in this sense here, the J point is right along the isoelectric line right over here. Right here, this time the J point is right over here, which is above the isoelectric line, and we're going to assume that this J point is greater than 1 millimeter in order for it to be a true ST segment elevation. And lastly here, if you have the isoelectric lines around here, the J point would be here. Then if this depression is greater than 1 millimeter, then that would be criteria for true ST segment depression. One other important caveat here to know is that just seeing an ST segment elevation or depression does not meet criteria for a diagnosis of any kind of cardiac ischemia going on. You have to always correlate with other ECGs, like serial ECGs, to track any kind of changes that may be happening, as well as the overall clinical picture to see if it's consistent with a myocardial infarction or myocardial ischemia. So first, we're going to go over ST segment depressions. And the two things we want to go over for ST segment depressions is, one, ST segment depressions are a sign of sub-endocardial tissue ischemia. The second thing is that ST segment depressions are not actually ST segment depressions, but rather everything else but the ST segment is elevated. So first, to go over endocardial ischemia, the reason why sub-endocardial ischemia happens is because of a partial occlusion of a coronary artery. So we're going to use this drawing here on the side to kind of illustrate what we mean by this. And if we look at the cross-section of here, we're going to take a cross-section here so that we can kind of look at the heart as if it were kind of flipped to its side. And now we can see the cavity left ventricle here as well as right ventricle here. And we're going to use these two diagrams here to kind of illustrate what we mean by sub-endocardial ischemia. So now I've repositioned and resized a little bit and drawn in some of the typical coronary arteries that we may see. And so the sub-endocardial region is the region of the heart that is abutting the cavity of the ventricles here, or the atria, but it's like right over here. If you were to trace it out, it's right over here. It's right under where the cavity starts. The subepicardial region is out here. So what we're going to discuss is how a partial occlusion of a coronary artery, say it was halfway occluded, or actually it's a little bit more than halfway, but it was pretty occluded here, but some blood is still getting through, why would it affect the subendocardial region right over here. Now there are two things to consider. One is that if you have an occlusion, a very large occlusion here in the coronary artery, then of course less blood and less oxygen supply is provided to the heart muscle here. Now, because there are penetrating arteries going in from here down to get all to the space, but along the way, the heart muscle is taking up any kind of oxygen that's available. So if there's less oxygen to begin with at the epicardial side, then all the oxygen will be used up here before any of it is left over to go to the subendocardial portion. So you may end up with some ischemic tissue right around here. It would be corresponding to this area here up on this diagram. Now, there's the distance issue, as well as the second reason why this subendocardial area is susceptible for ischemia is that the subendocardial tissue is getting the brunt force of the entire ventricle here. All the muscle here is creating a huge pressure right on this area to be able to squeeze the blood that's inside the left ventricle, correct? So by the same token, if you have huge pressures, the biggest pressures right here in the subendocardial space, then you have these penetrating blood vessels that are trying to get to the myocardium here, except since there are very high pressures basically kind of pushing away the blood, if you have less blood supply to begin with, then it won't be able to fight against this hydrostatic pressure that's pushing outwards all the time. So that's another reason why this subendocardial region is more susceptible for ischemia when there is a partial occlusion. Now we'll need to observe how this ischemic tissue here and here may overall affect the electrical signal that the ECG picks up. So let's say we take some healthy tissue over here, right by where it's not having any kind of ischemia, right? Let's say that's somewhere around here. Now, again, this is kind of out of the plane of this cross section, so it's actually on a wall that's kind of coming over like this, maybe, and then it's a positive charge around here. What we usually see is the charge kind of moving outwards this way, correct? or this charge kind of moving out toward us, out of the screen. What's important to understand about that charge is that the ECG says that the overall charge up here, for example, is moving out that way. But what's happening in reality is that the charges go out concentrically like this. Almost concentrically. So if we were to draw arrows to represent that, instead of the concentric circles, we would end up with something roughly approximating like this, with a little bit of a larger charge going that way. So as you may see, everything in terms of what the ECG is able to pick up cancels out with each other. The charge is propagating that way, cancels with that one. This one cancels with this one. This one cancels with that one. This one almost cancels with this bigger one, but there's a little bit left here, and that's what we see over here when the ECG picks up the overall signal going that way. So what that means is, if you have any kind of ischemia, for example, on this side of the tissue, so somewhere over here, these cells are no longer able to repolarize, as the cells are dependent on an ATP process requiring oxygen to properly repolarize in time. When this area depolarizes, and these portions are not able to depolarize because they were not able to repolarize in the first place, these vectors, for example, are still able to cancel each other out, but this one is no longer canceled out by that one. This one's no longer canceled out by that one. So this element of this vector may be canceled out with this element of that one, but this one is not canceled out at all. And this one for sure is not canceled out by that one. So what you'll end up seeing is an overall vector moving away from the portion of ischemia. And the one other important thing to note about this whole schematic here is that usually when you have a normally functioning heart, the depolarization of the heart at any given area, let's say over here where there's healthy tissue, is coordinated well, such that it's not constantly depolarizing in a random manner. It is depolarizing only when there's a signal that comes from the SA node moving to the AV node, going down the His bundle, going to the Purkinje fibers. That's the only time that it'll correctly fire. However, when you have ischemic tissue here, you have tissue that is persistently depolarized. So it's not able to repolarize. So you have tissue that's persistently depolarized next to tissue that is healthy and trying to repolarize. And you have this potential difference here. So you'll have random depolarizations happening at the border of where the ischemic tissue is and the healthy tissue is, just from the fact that there is quite a big electrical potential difference between the two areas. Another thing to consider is that as this ischemia progresses and the cells within the ischemic area start to destabilize and their cell membranes start to destabilize, it'll start leaking its contents, and part of what leaks is potassium. Now, if potassium goes into the extracellular space, it messes up with the membrane potential across some of those cells that are able to properly repolarize, thus making it much more easy for the proper cells to depolarize. This means that the healthy tissue right around the ischemic tissue is more likely to depolarize randomly without coordinated signal coming down from, as I mentioned before, SA, AV, His Purkinje fibers. Now, we went through all of that trouble to illustrate that at the border of this ischemic tissue and the healthy tissue, we will have a constant vector of depolarization moving outwards away from the area of ischemia, similar to here as well. Now, the overall vector here may kind of look like that, outwards that way, and the overall vector here may look kind of outwards in that direction. And this is happening constantly regardless of what other signals are happening around in the heart. So what this all means, if you have a regular heart and an ECG that looks normal, P wave, Q, R, S. And your T wave, what happens if you introduce an element of ischemia is like this. You have your sub-endocardial ischemic region with an overall persistent vector of charge moving outwards away from it. What that means is even at rest, you have an overall baseline, if you imagine like some noise or the signal here persistently there, right here, except when everything depolarizes after the ventricles depolarize, right? Then there's nothing else for things to depolarize around the ischemic tissue. So it'll go back down to its isoelectric line right here. So what this overall looks like is an ST segment depression, because you don't have what the normal was to compare it with on the ECG. But if you were to able to somehow look at a healthy heart and that same healthy heart suddenly develop subendocardial ischemia and trace that change over time between the ECG, you would see that the overall everything shifts upwards except for the ST segment here, where everything is depolarized and hits zero, just like what it does in a normal heart. We call this an ST segment depression, but in reality, it is an everything but the ST segment elevation. But of course, it's kind of cumbersome to say this, and we don't have the reference one to look at before, so we call it just like how we see it, and what we believe we see is an ST depression. Now, if you understood the ST segment depression and the physiology behind that, it's fairly easy to understand how ST segment elevations happen. So in the case of ST segment elevations, it's a little bit more severe version of an ST segment depression, in that in ST segment depression, what we saw is a partial occlusion, and in an ST segment elevation, you see the complete occlusion of a coronary artery. And what happens when you have a complete occlusion of a coronary artery is that you have, regardless of whether or not the tissue is on the sub-epicardial surface or the sub-endocardial surface, all of the tissue in this area is not receiving any blood supply. What you end up is the whole transmural thickness of the heart, including the sub-epicardial and the sub-endocardial and everything in between, becomes ischemic. And when you have that and pair it up with the previous concept that you had about the viable cells at the border of the ischemic tissue is constantly being depolarized, you have overall charge vectors moving away from the whole transmural ischemic area. So what you end up with is kind of like this. And it's a little bit harder to see since these are kind of almost moving out to the side, but what you would actually see is that the overall vector is going inwards like this, because this element of that vector cancels out with this element of this vector, but this element of that vector adds up with this element of this vector, so these two added together is equal to kind of like that. Same thing here, where you have this element canceled out with that element of this vector, and then this element of this vector and this element of this vector adds together to move things inwards like this. Now you may recall that when we had just the subendocardial ischemia, the overall vector was moving in the other direction. So if in the case of the whole transmural infarction or any kind of ischemia that doesn't allow for proper repolarization, the whole transmural area, then the vector goes in the opposite direction, which then you may imagine if you have a normal heart with a normal ECG that looks kind of like this, then if you have a transmural infarction, then what you'll end up with is an overall charge vector moving this way. And if you have an ECG lead, such as lead 2, that is detecting what vectors of charge are moving in this direction, then the overall charge vector of the ischemic tissue that's persistently going is downwards, away from lead 2. So everything will be pointing downwards, except for the ST segment portion again, because that's when everything is depolarized, including the cells right at the border that are viable right next to the transmural space, which are contributing to this vector going that way. Those are also all depolarized synchronously, so that'll reach 0, and then as things repolarize and the areas around here start repolarizing, then they will start again depolarizing it and giving that vector there. And if you look at this, if we didn't draw the isoelectric line across both of these and we were just looking at this in isolation, this would of course look kind of like an ST segment elevation in comparison to this. But if we were to look at the normal heart and then we would look at the ECG here and then trace and see how a full transmural infarction or ischemia would cause the ECG change here, we would see that actually everything here gets depressed downwards, including QRS signal here as well, and here as well gets all depressed except for the ST segment, because that's when everything is depolarized and you can't really change anything about everything being depolarized. It hits 0. So we have your ST segment here hitting 0. So again, this is called ST segment elevation clinically, but conceptually what it actually is everything but the ST segment depression. And yeah, that concludes the physiology of ST segment changes in cardiac ischemia.